of the stroke mimics, again, don't miss hypoglycemia, don't miss your sepsis, and don't miss your seizures, right? I always encourage is be the thinking provider, right? I don't like people that just I just follow the protocol X, Y, and Z. I want providers to understand.
Engine 23 and Medic 23, Larpenteur Avenue West and Fry Street. Police on scene. Shooting. Stand by for police. Box 546. On fire off score. Time 21:07.
Hey everyone, welcome to EMS Connect on Shift, your go-to podcast for everything EMS. Sometimes we're going to educate, sometimes we're going to review EMS articles or books, sometimes we just hang out with badass people and BS, but I'll tell you what, every time we're going to have an absolute blast. I am your host, Sean Pitts. I'm the head of education for EMS Connect. We are a top-tier EMS education organization that offers more education than you'll ever need. We have a website with hundreds of hours of education. We got online EMS refresher courses, and we even offer on-site courses. Before we jump into this episode, please take a moment to go to whatever app you're listening to this on right now and subscribe to our show, give feedback, and give our show a rating. Every rating you give truly elevates this podcast and makes it easier for others to find us. Please help us spread the word about EMS Connect and the On Shift podcast so everyone can get educated. And for the second time this year, I think we have the absolute pleasure of welcoming Dr. Micah Dang. So welcome.
It's good to be back.
10 seconds on yourself. You got these great pictures up here. Scared of flying. Also,
yeah. Don't like pre-hospital medicine. So I'm an emergency medicine provider, also EMS physician, medical director for various agencies here in Spokane County, Washington State, and I'm from Spokane. So
sweet. Well, I turn it over to you.
Awesome. Thank you so much. So, title for this is great. Clots Clues, Decoding Stroke in the Field. Stroke is not an uncommon chief complaint, right? Concern for stroke. And it's one of those time-dependent emergencies, which you will hear me repetitively saying, that we need to be quick with the diagnosis, identification, and management, and then rapid transport to the appropriate facility. So let's go ahead and dive right in. So stroke, let's start with the basics here, right? This is any vascular injury or insult that reduces blood flow to a specific region of the brain that causes neurologic impairment, right? That's the definition of this. And it's separated into two categories, is ischemic stroke and hemorrhagic stroke. In each of those categories, there's various causes of this. And what we're going to do is we'll talk a little bit about the anatomy, the function of the brain, identifying this, and then the different management modalities for each of those. But before we do, why do we care about this, right? The epidemiology of this is that stroke is a very common, as I said, this is a call that you have all been on, concern for stroke or stroke-like symptoms. There's about 795,000 strokes a year. Every 40 seconds, someone is having a stroke, which kind of blows my mind to think about. Every 3 minutes and 11 seconds, someone dies of stroke. So this carries a high mortality with those that are suffering stroke. And it is the fifth leading cause of death in the United States. Tends to increase with age. Men are more likely to have a stroke at a younger age. However, women have a higher mortality. And so it's one of those things is that we can actually do a lot of preventative measures. So you see, as we talk about risk factors, about modifiable risk factors to hopefully prevent stroke. But then for us in the pre-hospital arena, it's going to be identifying stroke and then treating this early, which is going to have a huge impact. So socioeconomic impact, I think this is something that's very important to be cognizant of. It's about $53 billion from 2019 alone, the cost of treating and managing stroke. And a lot of people don't realize is that those people that survive strokes, a lot of them will have residual deficits, and it impacts their daily functions, their ability to care for themselves. So oftentimes that they don't just go home, that they may require either assistance at home or require to go to a skilled nursing facility, a long-term facility, to be able to care for themselves essentially, and they need help, and that's a huge economic burden. This is the leading cause of long-term disability, as you can imagine. As we talked about just briefly, is that they're separated into two categories. The majority of strokes are going to be of the ischemic nature, and then 13% of them are the hemorrhagic. There's a huge in-hospital mortality, about 5 to 10% for ischemic stroke, and it's much larger for hemorrhagic stroke, about 40 to 60%. And only 10% of stroke survivors will recover completely, meaning that there's no residual deficits. But what we found, though, and why we will talk about later, is the stroke designations for hospitals about how do we determine where to take a stroke patient to. It actually matters, because the type of care that they get immediately, and then the post-stroke recovery care really matters in the recovery phase for these individuals. So a little epidemiology of why this matters. This is a common call, huge morbidity and mortality associated with stroke. So in an overview, this would be the most important thing to know at the end of this, if you can answer all this, is recognizing stroke, the importance of the last known well. You need to be able to identify stroke mimics. There's various different diseases out there that masquerade or have similar symptoms to stroke, and we need to be able to identify that and understand that those stroke mimics, even though if we're worried for a mimic, those are still serious diagnoses in and of themselves. What is going to be your management for stroke? And then the different stroke scales we'll talk about briefly, and then your transport considerations determining, depending on the scales.
So our first question, just to kind of pull the audience of some general knowledge or what our thoughts are here. From the following list, what is a risk factor for ischemic stroke? A, diabetes, B, working in EMS and fire, C, anticoagulation and antiplatelet medications, or D, chronic fatigue, lack of proper sleep, which I feel like maybe B and D kind of go hand in hand there. But so this is for risk factors for ischemic strokes. Give everyone about 5 more seconds to answer. So we got 63% of people say diabetes, 33% of people say anticoagulation and antiplatelet medications. So what's the answer, Dr. Day?
Oh, it's definitely B and D.
Absolutely.
No, so it's the answer is going to be A for this. So diabetes is a major stroke risk factor. So let's talk about ischemic stroke. Okay. So ischemic stroke, this is a blockage of an artery that prevents blood flow to parts of the brain, causing cell damage to that area. Okay. There's various different causes under ischemic stroke, as I talked about earlier. So thrombotic is going to be your most common. There's a lot of different causes of thrombotic ischemic strokes. And basically what this is going to be a thrombus or a clot that develops at part of the brain due to various causes. So that can be due to just atherosclerosis. So we talk about plaques that can be heart disease, also cerebrovascular disease too. And that plaque builds up and then builds a thrombus, cut off blood supply to that area of the brain. It could be due to vasculitis, which is inflammation of the artery to that part of the brain, which causes a thrombus to develop. It could be a dissection or a partial tearing of the artery that causes a clot to develop in there. But basically, thrombotic is just, the name says itself. A thrombus, clot develops, blocks out part of that brain. Embolic is about 20%. And so embolic means that a clot develops somewhere else in the body and then propagates to that area of the brain, cutting off of the blood supply. So that clot originates somewhere else and then goes to the brain. Let me quiz you, Sean. So one of the things a stroke risk factor, which we'll get to, what puts you at prone to develop clot in the heart? What kind of arrhythmia do people commonly have?
Atrial fibrillation.
Atrial fibrillation, right? And so that is an embolic source where the atria, the top portion of the heart, is fibrillating. So the blood isn't being pushed forward because it's not contracting in a coordination fashion. So the blood can become stagnant. You develop a clot. And then that can propagate and cause a stroke. So that's an example of an embolic stroke. Another example would be if you have valvular disease of the heart, clot develops on the valve. It could be due to infection that develops a clot, or mycotic, where it's an infection on part of the heart that has a clot that breaks off and causes a stroke. So that's an example is embolic. There's also ischemic stroke due to hypoperfusion, and that's just where you have profound reduced cardiac output, or just extremely low blood pressure that you're not perfusing the brain. So you're not delivering the blood there. And that is the same etiology, right? You're just not delivering that oxygen and glucose to the brain, and it causes cell damage. So there's hypoperfusion. And the last one's cryptogenic, meaning we don't know. It's happened. We don't know what the source was. Obviously, that is going to be more rare, but the most common, you're going to have your thrombotic events and then your embolic events. So what about the risk factors? And this is what we're talking about. So diabetes is definitely one of them. We separate these into modifiable and then non-modifiable, meaning that modifiable, we have some control over, meaning we can have an impact prior to a stroke, right? So these are going to be listed here. Hypertension, very common, right? Diabetes, very common. Atrial fibrillation is sometimes a non-modifiable or modifiable factor. Smoking, definitely, we can choose to smoke or not, but that puts us increased for cerebrovascular disease. Obesity, and then elevated lipids, high cholesterol, right? So as you can see is that with diet, exercise, medications, we have some kind of control over these risk factors. And very common in the United States is a lot of high blood pressure, obesity, diabetes, and smoking, right? The non-modifiable risk factors is age and then your genetics. We really have no control over that. But with this, we're going to be increased risk for stroke. The older you are, family history of, and then your modifiable risk factors, hypertension, hyperlipidemia, diabetes, AFib, smoking, etc. All right, next question.
Yeah, so this one is basically the same idea, except for this one, we're looking for risk factors for hemorrhagic stroke. A, excessive exercise. B, drug use like stimulants or alcohol abuse. Or C, chronic hypotension. Give everyone about 5 more seconds here. All right, we got 75% of people saying drug use and 25% people think chronic hypotension. So answer for hemorrhagic stroke risk factors is?
This one is going to be B. So your stimulants, alcohol abuse is going to be one of the risk factors for this. So let's now transition to hemorrhagic, right? So this is our less common form of stroke, but carries a higher morbidity and mortality. So this is basically that you have vessel damage. You're not just cutting off the blood supply, but you have vessel damage and leaking of blood outside of the vessel, which causes a decreased perfusion in that area, cell death and damage, right? So this can be due to a lot of different kinds of vessel damage and or bleeds. So you have your intraparenchymal bleeds or intracerebral hemorrhage. A lot of these are going to be related to chronic high blood pressure, so hypertension. You have your subarachnoid hemorrhage as well. A lot of these are going to be associated with aneurysms. You have interventricular hemorrhage, which is bleeding into the ventricles of the brain. And then you have your epidural, subdural hemorrhages. A lot of those are going to be related to trauma related. But basically, this is vessel damage that causes bleeding into the brain, and then therefore that's causing lack of perfusion and or oxygen delivery, cell damage, cell death. So we do have our modifiable and non-modifiable risk factors. As we already said, one of these is going to be your stimulant abuse. And so jumping down to drug abuse, these are going to be your stimulants like cocaine, methamphetamines, those ones that are going to cause elevated heart rate, elevated blood pressure. That is definitely a risk factor. Hypertension and diabetes, similar to ischemic stroke, major risk factor for hemorrhagic stroke. Anticoagulation, this is kind of falls in the category of modifiable and non-modifiable as well, because if you are on a blood thinner, there's a whole laundry list of blood thinners out there, and you have any kind of injury, you are going to be more prone to bleeding, right? And that small bleed can turn into a big bleed. Your body's not going to clot as normal. So that is a risk factor as well. Smoking is definitely a huge cardiovascular risk factor. Hypertension, hyperlipidemia, elevated cholesterol, lipids, atherosclerosis disease. And then this one is kind of interesting too, is the liver disease. So your liver is very important in producing clotting factors for the body. So it kind of falls under the similar categories like on a blood thinner if you have underlying liver disease. And I put this under modifiable because there are some forms of liver disease, such as alcoholic liver disease, cirrhosis. That is a modifiable risk factor that if you stop drinking, the liver will regenerate and repair, and it's no longer an issue. But then you have the underlying liver disease that is, you can't control it, that there's just a genetic factor to this, that you have liver disease. So I would make it a non-modifiable risk factor. But essentially, it all comes down to your body ability to clot that makes you more prone to bleeding in those patients. And then you have your non-modifiable risk factors as well, so your age, genetics, and then if you have a arteriovenous malformation that's congenital or an aneurysm, you really have no control over that, and so that's going to be one of your non-modifiable risk factors. So the big difference between the ischemic stroke is that there's a blockage that hopefully we could intervene on to break up that blockage, versus a hemorrhagic, which is actually vessel damage and bleeding. And the management of that is obviously going to be different, because you don't want to give a clot busting drug to a hemorrhagic stroke that's already bleeding and it's going to make bleeding worse. Where an ischemic stroke, that's that time dependent manner to get them to intervention to be able to give them a clot busting drug and hopefully open up that vessel to increase the perfusion. All right. I do want to mention something here about TIA. And so this is a common thing that we throw around a lot of the times, of a terminology of that somebody's having stroke-like symptoms, but then they go away. And so the differential of this is going to be the same differential that we see for stroke. And there's a lot of mimickers of this as well. But it's going to have the same stroke patterns that you would see, but it's really that there was a transient neurologic finding and then those symptoms go away. So there's two definitions of this. There's the time-based definition that you have the sudden onset of stroke-like symptoms and they go away, they're less than 24 hours. That's a time-based definition. But we'd really transition to more of a tissue-based definition. And this is where you have that transient neurologic dysfunction, that the neurologic symptoms are there, they go away, but then on neurodiagnostic imaging, such as MRI, you're not seeing a stroke. Okay, so it's really differentiating is there neurodiagnostic findings of stroke on this. And so this is really more on the hospital side as we are working patients up for this, and concern for TIA is ultimately management of this. And really what we do on the hospital side is that we identify those risk factors and do modifying things. We look for AFib, we address high blood pressure, we address diabetes, we address lipids, medications, etc. But something that it's more of a diagnosis of exclusion that we're really saying for TIA, but just saying is like, oh, you had stroke-like symptoms and they're gone, this is a TIA, right? We need some more workup and then possibly neurodiagnostic imaging. So for stroke, the big takeaway from this, stroke symptoms are typically a loss of function. And what I mean by that, they're negative symptoms, that you're not gaining a function, you're losing a function. So weakness, numbness, I don't feel an extremity, right? Neglect, loss of vision. That's typical stroke-like symptoms. They're typically sudden onset that they can clearly say is like stroke symptoms started at this time, right? When you think about the underlying cause of this, whether that's ischemic or hemorrhagic, you have the insult, lack of perfusion, symptom onset. You can have progressive symptoms, both for ischemic and hemorrhagic. As you can imagine, if you block off a major artery, you have a penumbra area around that area that's getting some perfusion, but then as that blood flow is being progressively or longer cut off, that those areas around there are going to get less and less blood flow, and the symptoms can then progress. And lastly, we need to be looking for stroke syndromes. Now, I'm not going to go into a huge neurologic lecture on this. I do want to cover a couple stroke syndromes, but because the brain is so fascinating, and that there's specific parts of the brain that is universal that control parts of the body, we can localize a lesion based off of symptoms alone. And I think that's really important, for us to, on the pre-hospital side, to recognize stroke syndromes, particularly those big strokes, and then that'll show up on our stroke scales. But how that is going to translate into where do I take this patient, right? So typically negative symptoms, loss of function, be wary of the sudden onset. You can have progressive symptoms, and then the stroke symptoms that we need to be aware of. Sorry. So here is a very, very quick anatomy, physiology of the brain. So this is just looking at the brain. We have our frontal lobe, parietal lobe, occipital lobe, temporal lobe, and cerebellum. And right below the cerebellum is the brain stem. So there's various functions of this. The cerebellum controls coordination. The occipital lobe, we have our visual cortex. Our temporal lobe contains our ability to understand our Wernicke's area, which is in our language center. And then that connects to our ability to talk, which you can see there. That's more in the parietal lobe, which is our Broca's area. And then our frontal lobe is our executive functions, which makes humans humans, right? And it's also our frontal gauge center. And then in the parietal lobe, we have our main motor and sensory center, all right? So as you can imagine, if you have an insult to one of these areas, you're going to have a certain syndrome that develops with this, right? So I want to focus in on what's called the homunculus. Have you seen this before, Sean?
I have. It's kind of creepy. If you ever look up just how the humans would look based on a homunculus is eerie.
So what this is it's a visual representation of the brain in the parietal cortex, that if there's an insult to that area, the deficits that you would see. So if you're looking at the left of the screen here for the face, right, that would be the left side of the body, or left brain, that's controlling the right side of the body, okay? And so if there's an insult to that side, you're going to have potential motor and or sensory. So this is not something that I want you guys to memorize, but to be aware of, because when we talk about the vasculature distribution to these areas, this is where the homunculus and then our neurologists we can localize the lesion before we even get imaging, right? But we got to get imaging to determine the underlying, is this ischemic versus hemorrhagic, time dependence, if we can intervene or not intervene, and what to do for management purposes. So not something that I want you guys to be like, oh, I need to know the homunculus, but to be aware of this, because majority of the strokes that we see, particularly ischemic strokes, are going to be involving the parietal area due to the vascular distribution of mainly the carotid and then the middle cerebral artery to these areas, which is the most commonly affected. And then these are the syndromes that we start to see though, right? So stroke syndromes, right? We talked about sudden onset, typically negative. So motor and sensory deficits, dysarthria. So dysarthria is slurred speech, difficulty speaking. Aphasia is related to speech, and there's a receptive aphasia and an expressive aphasia. And if you've seen strokes, you've probably seen aphasia. Have you seen expressive aphasia before?
Yeah, where they just feel like they can't, you ask them to say, you can't teach old dog new tricks, and they're talking to you, but they're not able to articulate what you're saying.
Exactly. And a lot of times they'll be frustrated. They'll be visibly frustrated that they can't get their words out, so that's affecting their Broca's area. So that ability to talk area results in an expressive aphasia, because they know what they want to say, but they can't get it out. Now, a receptive aphasia, have you seen that?
Yes. Yeah.
Those are the people that you say something and they don't understand what you're doing. And you might take this as like, maybe they just don't like me, right? Or they're not listening to me, but they don't comprehend. And that is the language center that we talk about, the ability to understand, is aphasia. Now, a lot of times this is going to be associated, depending on how big the stroke is, potential motor sensory deficits, right? Dysarthria, the slurred speech as well. And then keep in mind, so that's talking about that main parietal temporal lobe area. But what happens if you have an occipital stroke? Well, that's going to affect vision. And so a lot of times in stroke, this is what's really hard, is that there's not a lot of the stroke scales, though they're starting to develop more, and we'll get to this a little bit later, that look primarily at vision, right? So if you have those posterior circulation strokes, they are harder to detect, right? But you can have loss of vision with this, balance and dizziness, right? Another common chief complaint that we see is dizziness, right? This undifferentiated dizziness. But if you have a stroke that affects the cerebellar area and nothing else, they might just have ataxia, right? They might not be able to coordinate or walk. And so their only thing is dizziness. So this is why it's a really good thorough exam. And then our stroke screening and stroke scales are hopefully going to be more refined to pick up on these more subtle strokes. Obviously, confusion and altered mental status, something that can be seen with any disease process, is concerning a stroke symptoms. And then headache and vomiting, right? Typically, those are going to be more associated with the hemorrhagic strokes than the ischemic strokes due to the vascular cerebral irritation due to bleeding, but that can be a stroke symptom as well. So this is a laundry list of symptoms that don't only fit into stroke, right? But we need to be cognizant and aware of, though. The big thing with this, though, is be concerned for sudden onset, and then the symptoms can be progressive.
Well, I think it's important. You're going to talk about it later when you talk about those like stroke screenings, right? Like the FAST exam. Mm-hmm. We just think that all of a sudden that the American Heart Association or whoever decided to add more letters to the FAST exam, but it's to broaden the ability of us to recognize other areas of infarct or other areas
Correct.
of damage, right? We're not just adding letters to add letters. There's a reasoning behind that. And then you have some providers who feel they don't need to know the anatomy, but understanding the anatomy allows you to understand those stroke screenings and all the screenings we do just that much more to be just better at our jobs and a better understanding.
Yeah, and this really translates to patient care and the downstream effects, right? If we miss this on the pre-hospital side, everything we do on the pre-hospital side sets the tone and projection for the patient on the hospital side. So if we don't recognize it early, what we do or do not do or recognize biases the hospital on what they're seeing, right? And it sets the patient at a trajectory. So again, this is a really in-depth stuff, a really broad overview, just to give an understanding of the anatomy of this and why things are changing, right? Why the FAST is now becoming BFAST, which we'll
and the practical application is dizziness and unable to stand, right? Mm-hmm. We transport them. You give a report that says patient has onset of dizziness and, not being able to walk correctly. Mm-hmm. And then maybe the nurse on the radio says, well, is this patient, was this patient be a good candidate for triage? And you say, well, yeah, there's nothing else wrong. They end up in triage, which now equates to a 1 hour wait, a 2 hour wait, a 4 hour wait.
Absolutely.
Now we're just like you're saying, it's just prolonging the treatment these patients could be getting.
Potentially, absolutely. So the arterial supply to the brain, again, this is just to give an idea of this, of the anatomy and how it relates to the cerebral cortex, right? So the vasculature we need to be aware of. So the anterior circulation is, so we have our common carotid that comes up and feeds do you have your pointer on here? So if you're looking at that picture on the left here, you have the common carotid that's coming up here, right? And so that's going to supply the circle of Willis, which is that circle on that picture on the left there. And that is at the base of the brain. And you're going to have the branches of your middle cerebral artery, your anterior communicating artery, and your posterior communicating artery. All right. That's a circle of Willis. Well, the circle of Willis is fed by the common carotid artery, which that's one there. And then on the left of that, you have the vertebral artery that comes up, and both the vertebral arteries come up to form the basilar artery. Okay. That basilar artery supplies the brainstem. And the brainstem, which I meant to talk about on that last couple slides ago, it's really our autonomic functions, right? This is what allows us to breathe without even thinking about breathing, right? And it has a lot of the coordination of the other higher executive functions that filter all through the brainstem. So you can have a lot of different stroke syndromes with occlusion of the basilar artery, but that is one of the big ones that can be affected that we could intervene on potentially if there is a insult to that area, right? So when we talk about our arterial supply to the brain, which we'll come back to for our stroke scales, these are going to be our large vessels, okay? So common carotid, our basilar artery, our middle cerebral artery, anterior communicating artery, posterior communicating artery. Those are our large vessels. And that's important because with more and more advances in medicine, we don't have just the clot busting drug anymore. We have thrombectomy, meaning that our interventional radiologist can go up and remove that clot, right? And that's been showing a lot of good promise and good patient outcomes, which actually expands the window for intervention beyond just giving them thrombolytics, which is really exciting. And this is why it's really important that we take those patients with those stroke syndromes to those centers that have those capabilities, and why patient destination really matters for these patients.
When I think early on, and at least when I learned strokes and stroke assessments and screening tools, it was anything outside of 3 hours was, oh, well, there's nothing the hospital can do. And I think EMS providers being educated it's not a hard and fast 3 hours. There are other things outside of 3 hours that are still a appropriate facility at the appropriate time. There's still plenty of things that can be done to hopefully reverse or at least remove that.
Absolutely.
That issue.
And another point I want to make here, with those large vessels that we're talking about here, as you can imagine, that middle cerebral artery, that common carotid artery, that basilar artery supplies a huge portion of the brain, right? So this isn't going to be somebody with a large vessel occlusion being like, I have facial numbness. And that's the only thing that you have on exam, right? So your stroke screening tools are really designed to detect those larger deficits that we're seeing supplied by those larger vessels. right? And like I said, the most common artery that's going to be affected is your middle cerebral artery, which that's where common strokes are like, oh, they have dense hemiparesis, neglect, right? Gaze preference. Those are the obvious strokes. The other ones that are still LVOs could be that posterior cerebral artery that's supplying the occipital lobe and the vision cortex, and they're having vision dizziness, right? And you're just like, oh man, that could have been easily missed on FAST if we're not expanding or looking for other strokes-like symptoms. All right, so quick stroke syndrome, right? The MCA syndrome. This is where the middle cerebral artery is involved. Like I said, this is going to be your most common. This is where you're going to have contralateral. So if the stroke is on the right side, you're going to have contralateral, meaning the opposite side of the body, paresis, and potential sensory deficits. Okay. You're going to have facial droop. That's going to be contralateral as well. Gaze preference is going to actually be towards the right, and you're going to have neglect towards the contralateral side. So they're looking towards the side of the lesion for this. I mean, you've probably seen this. This is the most common dense stroke MCA syndrome, or I should say stroke syndrome, that we commonly see. And so as you can see here, there's a picture of the homunculus on there of the things that you'd be seeing. This is a picture of that. So this lady's looking to the left. That's the side of the stroke. She's neglecting the right side of the body. She has sensory and motor deficits on the right side. All right. This is something that just to let you know is like, again, different areas of the brain are going to have different stroke syndromes. We could spend a whole series of lectures talking about stroke syndromes, which would be best by a neurologist that really focuses and nerds out on this. This is one of my favorite things actually as a med student, was in neurology, was they give you a constellation of symptoms and you have to localize the lesion to the brain of what's affected. This takes a lot of study, a lot of practice, but what we want to be is that know that you can have majority of these are going to be crossing over, but depending on area of the brain, you can have insults that are on the same side of the body as well. And so it gets a little confusing more as when it involves the brainstem or the spinal cord, which you can still have the strokes there. But be recognized, stroke symptoms stroke syndromes will be picked up, the big ones, by our stroke scales. Now, I do want to make another mention here about lacunar infarcts. Now, this is the internal capsule. This is deep within the brain. And the reason why I brought this up is that there are very, very subtle strokes, okay? And this is going to have to be your index of suspicion, because I think a lot of times we see people with like isolated numbness or tingling, and it's very difficult to be like, well, is this something I need to be concerned about or not, right? I think if we fall back on, is this sudden onset? Do we have neurologic findings, right? So even if it's just isolated sensory, and stroke risk factors are going to be playing a lot into this, right? You can still use your strokes, your stroke screening tool, stroke scales, but you still have to have that index of suspicion because some of these won't show up on either of them. And lacunar infarcts, these where you can actually have isolated sensory. So the internal capsule is the relay station from the cerebral cortex and all neurologic function in the body. All the motor, all the sensory filters through here. And if you have a small stroke, lacunar infarct of the internal capsule, you can have a pure motor or a pure sensory deficit that can appear very subtle. So a good physical exam is going to be very, very important. All right, now let's move on to stroke mimics. Stroke mimics are diagnoses that present like stroke but are not stroke. What I really want to stress here, though, is that these are all critical diagnoses. All right. So just because you're saying, oh, this is presenting as stroke, I think it's a stroke mimic, doesn't mean that that's not potentially a time-dependent emergency or something that needs to be addressed. I will say, though, if it's presenting like a stroke, looks like a stroke, that is a stroke until proven otherwise, though. So we still need to be going through our differential and being, this could be this, but given that I'm presenting with stroke symptoms and is following a neurologic pattern, I'm going to treat it as stroke, and then that's stroke until it's proven otherwise. So let's dive through the different categories of this. First one, neurologic disorders. Seizure. So this is going to be one of our most common stroke mimics. So seizure is going to be excessive electrical stimulation parts of the brain. You can have a focal seizure or you can have a generalized tonic-clonic seizure. And The confusing thing for how this can be mistaken for a stroke is your focal seizures is what I'd be really concerned about. For example, I just took care of a patient a couple days ago. She came in, family said that she's not acting normally. Seems more confused, and she's really not following anything that I'm saying. And so came in and it was like, well, maybe this is urinary tract infection. And as I'm talking to her, she appeared to have a receptive aphasia. She had no idea what I was talking about. Now, everything else of her neurologic exam was fine. So I didn't have a solid last and well. She was outside the window for obviously little therapy by the time of this, because we didn't really know how long this has been going on for, but it's sometime within the past 24 hours. Nonetheless, we got imaging. All that came back reassuring. And then when she got back to the room after imaging, she started to have some rhythmic movement of her hand. And it's just like, oh, is this seizure? Hooked her up on an EEG, and she was having a focal seizure, right? So easily missed a stroke. My concern there was that I had stroke findings, and later we found I was like, oh, she's in status with a focal seizure. And we treated that. She was fine. So seizure can be, typically we're worried about those focal seizures that can masquerade or have stroke-like symptoms with that. Now, additionally, that is the post-ictal state of stroke that we need to be worried about. So Todd's paralysis, aphasia, or neglect. Those are people that had generally as a generalized tonic-clonic seizure, and as they come out, they could have paresis of extremity. They have weakness, numbness, difficulty speaking, neglect. Those are going to be typically like you had a witness seizure and you had that happen. Now, what I would say for these people is that you got to treat the patient in front of you, right? If you have a history as like, I have a history of seizures, or family saying they have a history of seizures, and when they come out of their seizure, this is exactly how it is, it's like, great. If this is not, I would err on the side of caution, depending on what is the syndrome that they're presenting with, is how to manage that at that point, right? If this is persistent symptoms, is like treat that as a stroke, with the differential is that this could be Todd's paralysis. We just saw a seizure, but keep in mind what triggered that seizure. So could it be a hemorrhagic stroke? They had a seizure and they're having deficits, not just because of the seizure, but because they've actually bled. So treat the patient in front of you is a big point here. But if you have a patient that's like, yeah, they have epilepsy, and every time that they have a seizure, they come out, they have difficulty moving their left arm. This is the same thing. I would be less concerned. Obviously, we need to be seizure management care at this, but lower suspicion for stroke. Now, migraine with aura or complex migraine. This is a diagnosis of exclusion. So people with migraines, they can have what's called complex migraines, where they get a headache. Sometimes they don't even get a headache. They may just get aura visual disturbances. And then they can develop stroke-like symptoms, where that's weakness, numbness, again, difficulty speaking, aphasia. That's really masquerading as a stroke. Now, again, that's a diagnosis of exclusion, meaning you see that patient, you have stroke-like symptoms, you treat them as a stroke. If this is, again, family patient says, I get migraines, this is my migraine, and I get this afterwards, that's where you're going to have to use your clinical judgment. Is like, okay, this is exactly how this is. Where is my transport destination going to be based off of that kind of history, right? But I would say treat the patient in front of you. If this is something new, that's a diagnosis of exclusion. But complex migraines, you can see a lot of stuff that mimics a stroke. Multiple sclerosis is another one, particularly in those with multiple sclerosis with remitting, so relapsing remitting symptoms. So this is a demyelinating disorder where you can get white matter lesions within the brain or spinal cord, and you can get stroke-like symptoms, where that's numbness, tingling. Again, you can get visual disturbances with this, and the symptoms can come and go, wax and wane. People with multiple sclerosis can have strokes. Okay, so again, this is going to be coming to a good history and physical exam. Sometimes, depending on where the lesions are, it can follow a stroke-like pattern, meaning it's all on one side of the body. But it'd be rare for somebody to be like, okay, my right side of the face is numb, weak, and my left arm's weak, and my right thigh is weak, and then my left leg's weak. That's really not following a vascular distribution, so I'd have a lower suspicion for stroke in that. But a lot of times those people, particularly with the relapse and remitting MS, know the symptoms they get when they have a flare with this. But definitely can masquerade as stroke. Then we have our functional neurologic disorders. So this is previously known as the conversion disorder. These are real to the patient, and I'm not trying to minimize any of this. They have been associated with underlying psychiatric illnesses as well, or history of PTSD trauma, that when they manifest neurologic symptoms, but it's not a neurologic disorder. It's a functional disorder. So this is, again, a diagnosis of exclusion. And you got to treat these people like a stroke, because people with functional neurologic disorders can have strokes as well. But something that is not uncommon to see is people that have diagnosed, and basically this will be people that have been seen multiple times. They followed up with a neurologist or a specialist, and they've been diagnosed with this. And oftentimes these will be the same symptoms when they have episodes as well. And then there's transient global amnesia. So these individuals, it's not due to stroke, but these people will come in with confusion. They will have anterograde amnesia. So it's kind of interesting. Have you ever seen a TGA patient before, transient global amnesia?
Mm-mm.
So it's not real common, but I've seen a handful of these patients. Typically last less than 24 hours. And this is a diagnosis of exclusion again, but they have anterograde. It's one of the key features of this is that you'll go and introduce yourself to them, and then you'll come back 5 minutes later and they'll be like, you'll go and you'll say hello to them. They'll be like, who are you? And they're pleasantly confused because it's that anterograde amnesia. They're just not remembering anything. It's kind of like the goldfish syndrome. But again, diagnosis of exclusion. So what about our vascular conditions? All right, hypertensive encephalopathy. So people with extremely high blood pressures can actually become confused. They can have headaches, and they can manifest with certain neurologic disorders like motor weakness, sensory changes. Again, this is a risk factor for stroke. So if you're seeing this, and oftentimes in people with stroke, they have elevated blood pressures, you need to be treating that as a stroke. But it may come to find that they don't have findings of a stroke and that they were just encephalopathic, or their symptoms are manifesting because of really high blood pressure, which needs controlling. There are these next two is just for your situational awareness. There's something called posterior reversible encephalopathy syndrome. This is typically associated with really high blood pressure. Can manifest with headache, altered mental status, motor sensory deficits as well, typically associated with really high blood pressure. Again, diagnosis of exclusion. And then reversible cerebral vasoconstrictive syndromes, RCVS. This is a thunderclap-like headache. It's often it will present like a ruptured subarachnoid hemorrhage. This is just for your situational awareness. Your vascular conditions, majority of these are going to be associated with high blood pressure. And again, I just repeat, if you're seeing stroke syndrome, stroke patterns, treat it as a stroke. And then there's the cerebral venous thrombosis. So these are going to be on the venous drainage side of the brain of getting clots that develop. Typically, you're going to see these in people that are in a hypercoagulable state. It can be related to taking oral contraceptive medications. Pregnancy is another risk factor, unfortunately, for cerebral venous thrombosis, or if you have a congenital disorder that makes you more prone to clotting, you can develop these. A lot of times you're going to have headaches with this, and depending on what part of the brain that clot is, it puts a backup pressure onto it because it's the venous side drainage. You can develop neurologic symptoms associated with this too. And then metabolic toxic. So most commonly missed stroke mimic is going to be your hypoglycemia, your low blood sugar. So this is why it's very important. Always check a blood sugar on these people, right? Correct the blood sugar. If they're still having symptoms, you're treating a stroke, right? But correct the blood sugar though, because they can present with altered mental status, confusion, seizure, right? They can have focal motor sensory deficits. So correct the hypoglycemia. Also, if they're medications that are either prescribed to them and or illicit drug intoxication, you can have altered mental status, confusion, right, which are stroke syndromes. Also can result, as we talked about too, with stimulant use to elevated blood pressures and cause hemorrhagic strokes, etc. Your hepatic and renal encephalopathy. So if you're having renal failure, hepatic failure, these people have encephalopathic, where it's basically just confused, altered mental status. They can manifest with some neurologic symptoms. A lot of times it's going to be related to more confusion type states. And then Wernicke's encephalopathy. Do you know what Wernicke's is?
Nope.
So this is what we worry about with chronic alcoholics. And so chronic alcoholics, they become vitamin deficient, primarily vitamin B1, which is thiamine. And these people, this is a true emergency we got to identify. This can present mainly with more confusion, altered mental status. But one of the key features of this is this confabulation, where they have these kind of like grandiose stories that just don't really make sense, that we see with this. But this is going to be your chronic alcoholics that is going to be presenting altered. And basically what they need is glucose and thiamine. And we got to replace that thiamine over a period of time. All right, and then we have our structural brain spinal cord conditions that can mimic a stroke as well. So this is any mass effect such as a tumor, an abscess, which would be an infection, head trauma, so subdural hematoma, subarachnoid hemorrhage. That's obviously putting pressure on the brain, limiting blood flow to that area. And then our spinal cord disorders, whether that's abscess, infection, metastasis, primary tumor, et cetera, that's going to manifest as stroke-like symptoms, weakness, numbness, et cetera, altered mental status in the setting of brain abscess, tumors, head trauma, et cetera. And then lastly, infectious and inflammatory. So this is something that we definitely don't want to miss, right? And what he said is like, there's a lot of critical diagnoses in the stroke mimics that we don't want to miss. So systemic infection, whether that's meningitis, encephalitis, or they're just poorly septic and they're encephalopathic because of their sepsis and their infection, those people, we need to rapidly identify. This is a time-dependent emergency as well, right? Time to antibiotics is very important. So recognition is going to be key in these people. But keeping in mind is that you can have neurologic symptoms that are developing from this, and keeping stroke on the differential, but identifying that infectious inflammatory state is going to be also important.
And would you say, I mean, likely with sepsis, you're going to have other pieces to point towards sepsis, right? You're going to have tachycardia, you're going to have low blood pressure, you're going to have some sort of temperature irregulatory, hypo or hyper, you're not just going to have just it looks like a stroke, but I'm also thinking sepsis. You're going to have other findings that are going to point you more towards sepsis than stroke, right?
And one of the things I always stress though is like, call a spade in the sense of that, one of the things is that we always say is like, a patient can have as many complaints as they want, or chief complaints as they want. They can present with as many symptoms as they want. And we always say is there's an Occam razor, meaning that the likely diagnosis is explained by one thing, then multiple things. But keep in mind, somebody who is septic could also have endocarditis while they're septic, and they embolize the stroke to their brain, right? So yes, you're absolutely right. This is why history and physical is key on this. You get a good history. I have somebody who's right-sided paresis, they're febrile, they're tachycardic, history of IV drug use. This is sepsis and stroke I'm worried about, right? And so you're going to have to be able to reconcile that to be like, I got to be able to treat both, right? So the treatment destination for that individual, I'd be like, I need to take them based on my stroke scale to the stroke center, because of this is the picture I'm sending, but I'm worried that this is also underlying sepsis as well, and making sure that we're getting that pre-hospital notification for both stroke and sepsis. But Occam razor would say it's like there's usually one unifying diagnosis, then multiple different ones at the same time. But in sepsis, it's like definitely could be is this endocarditis type picture, or is this just somebody that is profoundly hypotensive and they're septic, they're hypoperfusing their brain, manifesting neurologic symptoms, confusion, etc. And that's the main thing that needs to be addressed here, right?
Right. So playing devil's advocate, what if you have stroke on one of your differential diagnoses, right? And you have possible heart attack on the other one. Now we're talking about, well, I want to give aspirin. I want to give aspirin because I think it's a heart attack. But what if it's a hemorrhagic stroke? How do you balance those two things? Is there a situation where you can think of that those two would cross over?
Dissection.
Okay.
So somebody who dissected the coronary artery and dissected up, so they're having stroke-like symptoms and chest pain, and on their EKG they're showing a STEMI.
Right. So they get aspirin?
So if I'm really concerned for that, I would hold off on aspirin, right, in that situation, and be ready to explain myself upon arrival to the hospital, right? But I always say is chest pain plus neurologic finding, I'm worried about dissection particularly, even if there's not a STEMI on the EKG, because they might not be dissecting on the coronary artery. That's a great thing. And I always encourage is be the thinking provider, right? I don't like people that just like, I just follow the protocol X, Y, and Z. I want providers to understand You got to obviously work within the lanes of the protocols, but be a thinking provider by the means of like, I'm worried about this. Not we stress, yes, cardiac STEMI gets aspirin, but having a reason why I'm holding off on aspirin in this situation, which could be key. Great question. Now, another question I have for you is, which person between these two is having a stroke? We see both of them are having a facial droop. The lady on the left has a right-sided facial droop, and the individual on the left is having a left-sided facial droop.
I'm going to guess the individual on the right.
Individual on the right.
Yep.
Are we able to poll people on this? Are they able to?
I don't know. We probably could have, but we don't have. We don't have it in here. So I mean, maybe if someone can pipe in, but what do you think?
Does anyone want to?
Well, I guess you have the answer.
Well, let me quickly look this up.
Yeah, got to Google it and see which one.
So this is one of the
Ask AI.
This is one of the stroke mimics, right? This is Bell's palsy, right? What we're getting at here. So if you have an individual with an isolated facial droop, what we're really worried about is this person having a stroke or not? This is on the FAST exam, the BFAST exam, right? Facial droop. Are we seeing a facial droop? So both of these people would be screening positive. The differential from this is that they need a very, very, very specific, and detailed neurologic exam to really diagnose Bell's palsy, because this is really it's a diagnosis by physical exam. This really doesn't require neurodiagnostic imaging because of the pattern of this. The lady on the right, as you can see, her forehead on that right side is not wrinkling up. So you see is that she's weak on that right side of her forehead. The individual on the left, his forehead's wrinkled up. So he's not weak on that left left side of his forehead where the facial droop is lower, because you see he cannot smile on that left lower side.
Right.
So they both have a facial droop, but what we see here is one is affecting the forehead and one is not. Now, the person who is having a stroke is actually the individual on the left. So Bell's palsy affects the forehead. And the reason is that the forehead has a dual supply from the brain from both the left and the right. So if you have a central stroke, meaning you're actually having a stroke, because it's dually intervened on the left and right, it spares the forehead because the forehead is still going to be stimulated to work. Because Bell's palsy, which is inflammation of cranial nerve 7, which is the facial nerve, controls motor function, it's a peripheral nerve, and that's affected, it's going to therefore not work. So in Bell's palsy, it affects the forehead, and in stroke, it's forehead sparing to differentiate those two. Now, again, these people need a very detailed.
So would it be appropriate question after doing your BFAST exam, which you are going to talk about? You do BFAST exam, would it be appropriate just to grab a question and say, hey, can you raise both your eyebrows to see if their forehead is involved or not involved, to be able to say, I think this is Bell's palsy versus I think this is a stroke?
You can definitely do that. What I would say though is, because there's other cranial nerves and really detailed stuff that you need to affect, particularly testing cranial nerve 6, and then also doing a full head to toe neurologic exam, is that I would treat the patient in front of you. So it's like, I would still say is like, I would treat this as a stroke with ideas like this could be Bell's palsy. Now, the cause of this is typically viral. Typically, this is treated with antivirals and steroids, and the Bell's palsy can last for weeks to sometimes months, and then typically those symptoms subside after the inflammation of that nerve goes down. But if it's sudden onset, greater than 24 hours, and a facial droop, and you say it's like, because a lot of times the Bell's palsy I've seen, there's been some that have been clear, like this is a Bell's palsy, and there's some that are very subtle, be like, is that forehead coming up? Is it, and so there's subtleness to this. And what I would not want to have happen is that we have somebody with a clear time of onset, and it's like, oh man, looks like that's involved in the forehead. They can't wrinkle their eyebrow. We're good. We don't need to trace. This is not a time-dependent emergency, and go in. It's like, oh shoot, that really was affecting the forehead, and we missed the stroke. So I would say is that, I think it's really good to be able to identify this, to say, hey, I'm activating a stroke. They are BFAST positive. And then naming your stroke scale, determine on where your transport destination is. I'm concerned that this could be a Bell's palsy. However, time of onset is this, ETA is this, and then let the hospital figure that part out, right? But I think it's good is like, it's always there on the side of caution in those time-dependent emergencies. From versus like, somebody that's like clear, like I've had Bell's palsy before and it's clearly cut, then that's a little different story, right? But if this is like sudden onset and it's like, I would err on the side of caution. That's a really good question.
Sorry to jump in and interrupt, but all successful podcasts have advertisements. This podcast wouldn't exist without EMS Connect, an online, self-paced CE platform for all levels of EMS providers and firefighters. Our site houses over 140 hours of nationally accredited content for all levels of EMS. Access to our site is only $7.50 a month. There are no join fees, cancellation fees, and definitely no bullshit. We also host monthly live sessions where you have the option to interact with our talented and engaging instructors. Just for listening, you will be automatically entered to win a $50 Amazon gift card, which will be drawn at the conclusion of each of our live sessions. All of our courses we offer can be easily imported to your NREMT profile with a few simple clicks. This greatly simplifies your recertification process. All of this can be yours for only $7.50 per month. In this economy, we're spending more than that on our daily coffees. But wait, there's more. Our site also offers EMT, advanced EMT, and paramedic level NREMT refresher courses that are 100% online and self-paced. For all of your training officers out there, we make your job super easy with our administrative tools such as uploading agency courses, skills tracking, participation reports, and so much more. To get a no-catch peek at the administrative tools and capabilities of EMS Connect, contact us at info@emsconnect.org. Again, info@emsconnect.org. All right, enough of the advertisements. Let's get back to this great episode.
So dizziness, so this is just to complete our stroke mimics. And something that I want to kind of stress here is dizziness is a very common complaint that requires a really good, again, history and physical exam. And oftentimes when we talk about dizziness, people want to separate between vertigo and syncope, right? Or pre-syncope, sensation I'm going to pass out. Etiologies of this are different, okay? When we talk about syncope, we think more of heart-related. Are they going into an arrhythmia? Is there a hyperperfusion, poor cardiac output? Is this anemia, low red blood cell count, etc.? And when we think about vertigo, we separate this into peripheral and central vertigo. And peripheral vertigo, you may have heard this, is the benign paroxysmal positional vertigo is a type of that. Your labyrinthitis, basically it's a peripheral nerve issue that's causing dizziness, vertigo, spinning sensation, or a sensation of unbalance. What we really care about, and why I'm talking about it here for stroke, is that this is going to be the central vertigo that we are concerned about. That's going to be your posterior circulation strokes, blood supply to the posterior circulation, tumors affecting that area that could be causing dizziness, right? So some stroke mimics in there, but then also stroke that we're worried about. And you may have heard of this as more of a situational awareness of this, of a HINTS exam. So it's a constellation of physical exams that we can do to help differentiate between central and peripheral vertigo. That is something that was developed several years ago. It's gaining more and more traction and getting more evidence on the utility of that. I will say is not everybody's trained on the HINTS exam. This is not prime time for pre-hospital yet, but it really leads me into when we talk about be fast versus fast is that, again, our fast exam, our face, arm, speech time is really focusing on those most common affected areas, that middle cerebral artery area where we're going to see those stroke deficits. But when we see these patients with vertigo versus pre-syncope, we need to have this on the differential for stroke and really get a detailed history looking at risk factors, time of onset, any additional neurologic symptoms of do we need to be worried for stroke. So dizziness is something we see very commonly. We need to be doing a good screening, good physical exam. And one of the things I always advocate, and it's something that's been drilled into me, is I never discharge somebody from the emergency department without them walking. And so I want to see them vertical if they normally walk. I want to see them vertical and I want to see them walk. If I'm worried about a neurologic finding up front, I typically will walk them right away when I do my physical exam. I say that in the pre-hospital setting too, is that if this patient is able to normally walk, I'm not saying if they're like pre-syncope, I'm going to pass out, you're going to do this. But if they're like, I'm a little bit unsteady, do this in a safe manner, but see if they're able to walk. Are they having balance issues? And are you visualizing ataxia? I mean, that's very telling. Is like this person can't walk and they're falling to one side. That's concerning, right? But you wouldn't have ever got that if you're just like, all right, sit up, help them to a cot, and they're just like, yeah, I was feeling dizzy or I was feeling lightheaded, and you might be mistaking presyncopal type symptoms versus vertigo type symptoms, which could be concerning. So let's talk about, question first.
Yeah, we just recapping to make sure people are paying attention. So what is the most common missed stroke mimics? Bell's palsy, acute myocardial infarction, C, hypothermia, or D, hypoglycemia. Let's see if people caught, because you said it. It was clear as a bell. Clear as a bell. I don't think that was pun intended. I probably should have claimed that ahead of time, but that was not on purpose. Now everyone's clicking Bell's palsy that was the dead giveaway. But we'll see. Give everyone here about 5 more seconds just to see if they were paying attention. And we're going to close it right there at an exact 50-50 split between Bell's palsy and hypoglycemia. So what is the most common, most underlined, italicized, bolded, most common missed stroke mimic?
Hypoglycemia.
Yeah.
Hypoglycemia. This is why it's so important. Anybody, I would say, is that obviously anytime there's a concern for stroke, we're checking a blood sugar. I would also encourage anytime you have somebody with any confusion, altered mental status, GCS less than 15, better be checking a blood sugar on these people, right? Even if they're not a diabetic, check the blood sugar.
For our BLS providers, I know that's difficult because I taught education at the BLS level when glucose was not a national standard, right? Only certain states could do it, other states couldn't. But now NREMT has allowed glucose checks across the board, right? I know it's not a vital sign, right? But I taught that at the EMT program.
It's a 6 vital sign.
It's not. I wish it was. But yes, it's a procedure, but it should be used. Yes. It's just as important as blood pressure, as GCS, as heart rate, as SpO2.
Absolutely.
We should be taking glucoses on, arguably darn near every single patient we encounter.
Correct. Yeah. Particularly those, like I said, is like anybody with a GCS less than 15.
Take it
to get that blood sugar. And it's something it's the low hanging fruit. You can correct it and you identified it and you can fix a problem, right? That's the easy correctable thing with this. Of the stroke mimics, again, don't miss hypoglycemia, don't miss your sepsis, and don't miss your seizures, right? Those are all time critical emergencies that we can actually make a difference on. So again, when I talked about stroke mimics, this is not something to say is like, oh, I recognize this stroke mimic. This is an important diagnosis or an emergent situation. No, majority of those are critical diagnoses that require prompt evaluation and treatment. So again, you guys set the tone for everything that's going downstream in the hospital. So the early recognition of this puts that patient on the right pathway. And again, if it looks like a stroke, treat it like a stroke, but keep your broad differential. So be able to identify the stroke mimics, but if it's looking like a stroke, treat it like a stroke. All right. This was a fantastic lit review that looked at stroke mimics. And I really want to kind of go bullet point by bullet point on this, because what they looked at was what made a stroke mimic more likely than an actual stroke. So stroke mimics such as strokes can present in any way, right? We talked about any part of the brain can be affected. You can have many different presentations of stroke. There are no features that reliably differentiate a mimic from a stroke, right? Because of those mimics, you could still have parts of the brain that are being affected and has the exact same symptoms. Likelihood of having a stroke mimic can be broken down into 3 categories: the patient factors, the presenting symptoms, and physical exam findings, which are the least reliable as physical exams, which is interesting. So of the risk factors, if they're younger than 50, it makes stroke less likely. It doesn't mean it's not. There's a lot of strokes that happen younger than age 50, but it makes it less likely. If they don't have the risk factors that we talked about, hypertension, high blood pressure, diabetes, dyslipidemia, that's what DLP stands for, or high cholesterol, or a history of AFib, they lack those risk factors, make stroke less likely. Now, again, there's other risk factors, smoking, history, genetics, etc. But if they lack those, they found that that is more likely to be a stroke mimic. And if they have a past medical history of cognitive impairment, migraine, seizure disorder, that led to be more likely to be a stroke mimic. But again, that was a history of this happening previously, not saying that this is a complex migraine, or this is a seizure. Again, treat a stroke as a stroke. So of those risk factors, if they lack the risk factors, they're less than 50, they don't have any history of the seizure, migraine, cognitive impairment, then stroke mimic is more likely. If they're presenting with altered level of consciousness, right? We talked about altered mental status. A lot of those can be stroke symptoms. But if they have altered level of consciousness, chest pain, a gradual onset of symptoms or previous occurrence of this, intermittent, they're coming and going, makes it more likely to be a mimic. Now, again, I have seen strokes that have come in where they're getting symptoms and they're going away, getting symptoms and going away. This is like the intermittent left bundle in somebody who's having a heart attack, right? It's the same thing as that they're getting some perfusion, they're not getting perfusion, they're getting some perfusion, and they can be fluctuating. But with this lit review, they found altered level of consciousness, complaint of chest pain, gradual onset, previous occurrence or fluctuating symptoms, more likely to be a stroke mimic. And then the physical exam findings least reliable, normal eye movement, normal neuro exam, or stereotype movements, I mean like flaying of an arm, that kind of stuff is less commonly a stroke. So of this, what I would take away from this is that this really emphasizes the stroke risk factors of who we're really going to be concerned of, those over 50, those with risk factors. And then the altered mental status, chest pain, gradual onset, fluctuating symptoms may be more of a stroke mimic. But again, go back to it. If it looks like a stroke, treat it like a stroke.
Mostly because stroke treatment in the pre-hospital setting, especially at the BLS level and arguably at the ALS level, is transport, right? We're starting IVs, and that's pretty much, there's no magic stroke drug that we're currently not in most systems, right? I know some systems are doing, I think some systems that are doing like CT in the field or something like that. But in most systems, BLS and ALS treatment is transport.
Well, and I think that this is the less sexy of topics a lot of times for pre-hospital providers because of that.
We can't do anything.
The key to this, I think, is the part that I give credit is the recognition. And I think that is the hardest part of this, is that it's those subtle strokes that you could pick up on being that good sleuth of really getting that good history and physical exam and identifying that stroke that otherwise would have been put in triage for a 5-hour wait before being seen and be like, oh, wow, this person has had a stroke, right? And so again, this is not the most sexy stuff because we're not intervening, doing procedures or doing a lot of the pre-hospital management. And again, there are some management things that we need to do. There is the blood sugar we need to check, which is obviously not sexy, but it's something that we cannot miss. But this is really coming down to that good history and physical. All right, so let's talk briefly about, so we all know the stroke screening school that we almost universally use. Now, there might be some systems that are not, but I'm pretty sure the majority of the systems we're using is the FAST exam, right? And some systems have been changing to the BFAST. So FAST, face, arm, speech time. I'm not going to spend a lot of time on this. I think this is something that we all know about. This is the screening tool we say is like, are we worried about stroke? They're FAST positive or FAST negative, right? But again, face, arm, speech, that's all right in that parietal lobe area, where is the most commonly affected area for stroke. Now, what about the posterior circulation, right? The occipital area, the cerebellar area that controls balance, vision. We miss those. Now, that's not a large number. It's not the majority, but we're missing those. So there was a systematic review that compared FAST versus BFAST, and with the addition of balance in eyes. So balance is saying, are they completing a sudden onset, unsteadiness, dizziness, or difficulty walking? This is why I'm saying is like, it's good to see them try to ambulate, not let them fall, but see how they're doing. To see, they look ataxic. They're having difficulty walking. For eyes, does a person complain of narrow vision, blurred vision, seeing dark spots, blind spots, or loss of vision? Just blank out loss of vision. That's concerning for eyes, right? And that's going to capture the visual part, so the posterior circulation. That increased the sensitivity and specificities for stroke. if we add on the B fast for this, right? So what that's going to do is capture those posterior circulation strokes, and it outperforms the fast, which would otherwise be missing those. So you add that on, you are going to capture more patients that are having the posterior circulation stroke that is otherwise being missed with this.
But I think I want to have you point out again, this is a stroke screening tool,
Correct.
right? This is not a stroke assessment tool, because you're going to now go into stroke scales,
Correct.
right? And that this is just screening. This is, are we thinking stroke or not?
Mm-hmm.
Then your agency or your protocol will likely have what you're talking about next, which is some sort of scale of number scale or whatever. And you're going to go through kind of a laundry list.
So again, this is going to be your, I'm worried about stroke. This is my capture. Like, I'm worried about stroke screening. I'm going to use my B fast. I'm worried about stroke. And then what we have in Washington State, and I'm in a majority of the systems out there, we use a scale, whatever scale that is. And that is to try to capture those that we're worried that are having a large vessel occlusion. Okay. Because that is where the hospital side of management is going to be key. Is like, is there another intervention besides just thrombolytics that they could benefit from, with potential interventional radiology, thrombectomy, and removal of the clot? So again, this is the screening tool. And then we use a scale for how big or how concerned of where this stroke could be. Is this major deficits that we're seeing that could benefit from other additional therapies? So time is brain. We heard of this. Time is heart for myocardial infarction. Time is brain. And your brain needs two things to function: glucose and oxygen. And the third thing is a way to get there, right? So we can correct the glucose. If that's low, correct that glucose. We can give some supplemental oxygen, right, if they're hypoxic at all. But if they don't have a way to get there, we need to be diligent and rapidly identify that and then get them to a center that can. So that's where it's really coming important. Okay. Do you know, little quiz here, who this is?
No.
I always put up
I know. Why is it you're always
it's a Wyatt Earp.
Yeah.
No, this is Sir William Osler. So this is the father of modern medicine. And he has, it cut off
on the bottom.
Oh, no. So he has this quote. It says, listen to the patient. He is telling you the diagnosis.
You keep talking. I'm going to fix it.
Oh, well, there it is right there.
I know. You keep talking.
Oh, so I always talk about this because if you really truly listen to your patient, they're going to be telling you whether that's the history and or the physical exam that you're doing. So we got to touch our patients. We got to do a physical exam. Get the corroborating history from family, any caregivers, etc. But stroke is one of those processes that we can make a big difference on if we get the right history here. The last known well is going to be key. So, for example, if someone wakes up at 6 a.m. in the morning with stroke-like symptoms, when's their last known well? We don't know, right? So that's where this is going to be really important to be like, is this something that were they fine when they went to bed? Did they wake up with these findings? Were they seen at 6 a.m. and fine? And did they develop stroke symptoms then? So that last known well is so important. And I would say is majority of the providers that are listening to this can relate to is the grilling that they sometimes get when they come to the emergency department and we're like, when's the last known well? When's the last known well? When's the last known well? Are you sure that this is the last known well? Particularly those that are coming from like some, the history is a little bit questionable. We really don't know. Nursing home where you go there and the providers there are like, I don't know, I just came on shift. I really don't know this patient. But they
every time somehow they're always coming on shift,
right? I'm just coming on. I really don't know. But this is where we got to be the sleuth, right? And then looking at, well, they got their meds at 6 a.m. and they have a dense left MCA syndrome that I'm seeing in front of me, left dense hemiparesis. Who gave the meds? Because I guarantee this person couldn't swallow the meds with what they're presenting with now, but they got their meds, right? And so looking at the MAR, looking at anything else to get that information is going to be really key because that last known well is going to be very important. This is it. Here we go. There you go. All right. Look at the stroke risk factors again, right? Age, hypertension, diabetes, hyperlipidemia, elevated cholesterol, smoking history, AFib, history of stroke is going to be really key. And then obviously medications. Are they on blood thinners? Really, really, really important, not only for ischemic stroke, but a hemorrhagic stroke, right? That making the hemorrhage worse. Is that going to need to be reversed? And then also if they're on blood thinners, that would be a contraindication to give lytic therapy, right? So we need to know the medication list as well.
I think that's one of those, as a newer provider, that needs to be added into your question box. Sample and OP-QRT are that common. Just follow up. Are you on any medications? Are you supposed to be on any medications? Are any of those medications blood thinners? Because on the general falls of geriatric population, it's important. On trauma, it's important. Just should start becoming a just routine question you're asking. I would say almost every single one of your patients.
No, that's a very good point. So good history, get that last one well, look at their risk factors, identify medication. Very important is going to be your blood thinners. So your pre-hospital assessment here, ABCs, right? We got to go back to BLS saves lives, make sure the airway's intact, their breathing, circulation's intact. All right. Remember, oxygen is a drug. And this is something that is really key for critically ill patients when we talk about hyperoxia. And even this comes to MI, stroke, is that if they're not satting below 90, they might not need oxygen, right? A little oxygen doesn't hurt, but too much oxygen, it actually does have detrimental effects. So titrate the oxygen appropriately, but just because you're worried about stroke, don't throw them on a non-rebreather, right? That is actually not good for the patient. So oxygen is a drug. Manage the hypoxia and keep them within that above 90 range. IV is going to be very important for our advanced and paramedics out there. 20 gauge or larger in the AC or above. And the reason why I say that is we need a CT lineable line. We need something that we can push contrast through. And I cannot stress how important that is and how much time that saves of a patient arriving with a solid IV that we can draw blood and get them right to scan and give them contrast and get that CT that we need. There's been a lot of delays, somebody with difficult IV sticks that we're having to use the ultrasound, et cetera. But if you can get that IV, get that IV. That is going to be a huge difference. Now, position of head of bed. We want the position elevated, all right, for our pre-hospital management, scene management for stroke. Now, keep in mind, hemorrhagic stroke is going to be bleeding within the brain. You're going to have increased intracranial pressure due to that blood. And one of the things we want to mitigate that is try to decrease the intracranial pressure. So head of bed position, let gravity work in your favor, right? Laying them supine increases ICP. So head of bed elevated for them. I'm going to talk about a study for those with LVOs in a little bit. And I want to separate this out because that is purely for those with known large vessel occlusions for transport. We want them head of bed flat.
And that's going to be probably more facility, right? That's hospital to hospital.
Hospital to hospital with known diagnostic imaging of an LVO. So pre-hospital management, I want that head of bed elevated because we don't know if this is ischemic. We don't know if this is hemorrhagic. And so we're going to err on the side of that. We're going to do what's best for the patient in case this is elevated ICP.
Is this something I'm thinking in the fire side of things, right? You arrive at a patient's home, they're laying in their bed, you're doing your stroke assessment, you got all this great information. Last time C normal was an hour ago. They got, a positive BFAST exam. They got a LAM score that's appropriate. While you're waiting for an ambulance, would it be appropriate to pad some pillows behind the patient's head and elevate them in their bed?
Absolutely.
Okay.
So I always say it's like, differential. Are we worried about trauma or not? Do we need spinal precautions? If we're not, it's also a position more of comfort and breathing.
Absolutely.
Too, right? So
and airway control, everything.
Exactly. So if they start vomiting, you don't want them supine. You want them sitting up. So it's overall better management for you to manage them in the pre-hospital area. It's going to be more comfortable for them. And again, the supine position for large vessel occlusions is only for those with known LVOs, and we'll get to that in a little bit. So head of bed elevated though. Get that IV, follow your ABCs, get that glucose. All right, so thorough neurologic exam. GCS, if they're altered, it's good to have the GCS. And I know that I talked to you about this previously, but I'm going to ask you again. Of GCS, eyes, verbal, motor, what is the most sensitive and specific of those three?
Motor.
Motor, absolutely, right? So eyes, you're just like, are they open? Are they looking at you?
Right.
Are they closed? You tell them to open them, they look at you. How many times do you transport somebody and their eyes are closed because they're just resting, right? But if you're doing the GCS, you're like, well, that's one off her eyes. It's like, really? And then confusion, right? The verbal portion of this, that there is a subjectivity to this, that's also influenced by a lot of other things like intoxication, et cetera. It doesn't mean that GCS is not accurate, but it's a subjective nature to that. But motor is something that's reproducible. You take one provider, they do a motor function on somebody that's having a neurologic insult. It's going to be repetitive, right? And so that is going to be your most specific. Really important in the setting of concern for trauma, decrease GCS, decrease altered level of consciousness getting to GCS, and looking at their pupils. So particularly in hemorrhagic portions of this, pupillar exam, decreased level of consciousness, hemorrhagic stroke, pupils are going to be really important as well. So always look at the pupils, get the GCS. For speech, we talked about dysarthria, so that's your slur speech. Remember your aphasia versus expressive versus receptive, right? The receptive, they're going to be not understanding, not really following commands. The expressive, they're going to have difficulty getting words out. They might get words out that are inappropriate, and they typically are going to be frustrated at this. They know what they want to say, but they're just unable to say it. Weakness, right? So facial droop, test it all 4 extremities for weakness, and then sensation as well, right? Are there any sensory deficits from one side or the other to the one side of the body or the other, right? Without getting too much to the weeds of this, there are different sensory modality pathways from just like simple light touch to painful stimuli. I'm not saying that we need to go into that kind of detail with this, but you will see us do that on the hospital side. But assessing for sensation is going to be important. All right, now what about blood pressure management? I think that this is a hot topic because we always say is like one of our big risk factors for stroke is high blood pressure, right? So intuitively you'd think is like, I had somebody with extremely high blood pressure, should I lower it, right? Should we all be carrying blood pressure medications in the rig and lowering people's blood pressure with suspicion for stroke? Let me back step here. No hypotension. So we talked about like, okay, high blood pressure is a risk factor. Do we need to address that? One thing we do need to address is a low blood pressure. So if somebody is hypotensive, we need to bring up that blood pressure because the mean arterial pressure, as measured by our blood pressure, is going to be a component of our cerebral perfusion pressure. So if we have a low MAP, our cerebral perfusion pressure, our ability to deliver oxygen and glucose to the brain is inhibited, right? A hypoperfusion state. So we need to bring that up. So if somebody with stroke-like symptoms is a low blood pressure, we need to correct that, right? Fluids, if they need fluids, if you're worried about processes that requires pressors, then getting pressors on board is going to be important. The other converse to this though is what about the high blood pressure, right? That's a stroke risk factor for both hemorrhagic and ischemic strokes. So should we be lowering this? And this was actually looked at recently in a study here that was the Interact 4 trial, which looked at patients with concern for acute stroke and elevated blood pressure. And they looked at pre-hospital antihypertensive strategy, lowering their blood pressure. And it was not associated with long-term functional status compared to those that did not get blood pressure control. All right. So from this study that was in the New England Journal of Medicine, a high impact journal, this was just done in May of this last year. This is saying, no, we do not want to be doing aggressive blood pressure management. And the takeaway from this is that not just that do we need to be doing this, but we got to keep in mind is that, majority are the ischemic nature. There are a component on the hemorrhagic side that requires aggressive blood pressure control. But if it's ischemic, you might have heard of this permissive hypertension for stroke. And the idea behind this is that you have an area that is not getting blood flow, whether they get lytics or not. So if they get lytics, we have to drop it below a certain threshold. But let's say they don't get lytics because they're outside of a window. You want to be perfusing the other areas of the brain, and the natural response of the body to perfuse that is to raise the blood pressure up. So we don't want to blunt that, cause a decrease in the cerebral perfusion pressure in that area of the brain that is like getting some perfusion because the blood pressure is elevated and we're getting there. We lower it, and now we make that brain at risk, and we increase the infarct size. So there's this idea up to a certain point that we allow them to ride for this permissive hypertension and perfuse that areas of the brain that we don't want to act on. And remember, like majority of strokes are the ischemic nature. So I think that this is why we're seeing is that it was not associated with long-term beneficial outcomes with this, but more to come. This may change in the future, but from this study is saying is like we don't want to be aggressively treating blood pressure for patients suspicious for stroke. All right. So EMS triage and transport is very important, just like all critical diagnoses, the right patient to the right place at the right time. So this is, again, just like heart attack, time-dependent emergency, time is brain. So we have the American Heart Association stroke center categorizations. And this is probably not new to everybody out there because we're written in a protocol. There's likely a destination procedure or triage procedure based off of your screening tool and then your stroke scale of where do we take these patients. So at the highest level of care, we have our comprehensive stroke center. So these are going to be our stroke centers that have all the post-stroke care. They have IR interventional radiology capabilities. Obviously, they have the thrombolytic capabilities. Below that, we have our thrombectomy capable centers. So those are going to be centers that don't have all the resources of the comprehensive stroke center, but they have thrombectomy capabilities with IR thrombolytic care. We have our primary stroke centers that may have some thrombectomy capabilities, but not 24/7. Obviously, they will carry lytics. And then we have our acute stroke ready hospitals that typically are going to be just carrying the thrombolytics. Your destination is going to be dependent on your stroke scale, right? So again, the stroke scale is looking for severity of stroke symptoms based off of different physical exam findings. That is going to be suggestive is there a large portion of the brain that's involved that would be indicative of possibly a large vessel occlusion. All right. So just a little bit of history behind this is that this is why it's important to get the stroke scales, because it's going to determine where do we go based off of our stroke scale, neurologic findings, and transport time, right? So a lot of these will be built in. You'll probably read your protocols that says, well, if I have for example, in Washington State, is like we use the LAMS as our stroke scale. If we have a LAMS 4 or more, and our distance to a level 1 stroke center is X, then we want to go to a level 1 stroke center, right? And we're going to bypass a hospital. And this is why this is a little like groundbreaking with this, or would say is controversial at the start, is we're bypassing a hospital that has a drug that could potentially reverse the symptoms that this person is going to take them to another facility, increase that time to treatment, but ultimately they have more resources and capabilities to address other things. So this is a big deal. This is, something that might have had some controversy if you guys remember when this stuff was first coming out, that we're bypassing a hospital that has the treatment to go to another hospital because of potential of additional resources at that hospital that could benefit them. So again, let's talk about the large vessel occlusion. So these are going to be our arteries that we're worried about. The internal carotid artery, the basilar artery, which you pointed out beautifully, vertebral artery. So the vertebral arteries come up to form the basilar artery, your middle cerebral artery, anterior cerebral artery, and posterior cerebral arteries.
That's it? Just those?
Just those. And I put this up here again, is that you see the anatomy here that's pointing out the arteries, right? And as you can see, they supply different parts of the brain. Again, this is why it's really important, why we talked about the BFAST, which is going to capture more of these symptoms that could be affected or the presenting findings, particularly in the posterior circulation, which can still indicate it's going to rule in stroke, which then we're going to be like, now we need to use our stroke scale to say, am I worried about an LVO, right? Now, I will say this, as we go forward on the stroke scales, there is no perfect stroke scale. So as I said, in Washington State, we use the LAM score. That's not universal across the board. There are several stroke scales that we're going to talk about in just a little bit. But again, this is used to determine the severity of the neurologic deficits and the suspected stroke due to LVO that may benefit from thrombectomy with interventional radiology. Again, several stroke scales, not one is perfect, not one is superior to all others. As we get more data, we might find that one is performing better, and then hopefully, the education will come out, and then AHA will be supporting this, and we'll be saying this is the one we should be using. But there's no perfect or superior stroke scale. Signs and symptoms suggestive of a large infarct and LVR. These are your cortical signs, right? So conjugate gaze deviation, aphasia, neglect, hemiparesis, right? It's mainly those caught in the parietal lobe, right? Like I was saying, like with the FAST, but this is why we need to expand this out, because there's other LVOs that are not being caught with this. So it's really, that's where I think as these stroke scales become more refined, you're going to see some additional stuff added on, because as we'll get to, the LAM scores, that doesn't pick up any of the posterior circulation, right? And so we'll get to that. All right. What do we do in the hospital though? So when a patient comes in, we get a NIH stroke scale, and I'm sure you heard of this. So this is the higher the stroke number, the more severe the stroke. And this goes from everything from, it tests basically everything down from level of consciousness. And you ask questions regarding that. You're going to have their gaze, any visual deficits, facial palsy, motor weakness in each four extremities, sensory, ataxia, language. So that's testing for aphasia, dysarthria, extinction, and attention neglect, right? And you'll get a scale of this. Higher the number, the more severe the stroke. That's what we're doing in the hospital. This is not something we can be doing in the pre-hospital setting in a time efficient manner. So it's not something that is commonly used pre-hospitally. We're not getting NIH stroke scales in the field, right? What we need to do is pare that down into what is the biggest thing that's going to most affected or common in LVOs. That's what the stroke scale is trying to capture here. So this is a nice resource that was looking at the different stroke scales, and we have the references here of what this was. And so as you look on the left here, that's the stroke scale that we're seeing. This is the findings in the middle, which is really interesting on the specificity and sensitivity. So the sensitivity is the ability to detect a stroke if it's there, and the specificity means that if it's screening positive, that it is a stroke, right? So it's not only picking it up, but that's saying it's like, this was truly a stroke when it's telling you it's a stroke, right? So what you want is a high sensitivity and specificity, but you're never going to get 100% for both, right? So there's a simple 3-item stroke scale. This looks at level of conscious, gaze, and motor function. So you see that this one captures the visual portion of this, at least extraocular movements, but not truly vision. Sensitivity, specificity is pretty good. Sensitivity, okay, right? You have your LA motor scale. So this is what we use in Washington State, the LAM. So this is on facial droop, arm drift, grip strength. A LAM 4 or more had a 7-fold increase that a stroke patient was having an LVO. 93% specificity, 38 sensitivity. So it's not great at detecting it, but when it's there, it's specific, right? But if you think about this though, you're really not trying to have a real, so you already done your sensitivity with your BFAST because you're saying I'm worried about stroke, and then you're looking at, okay, now I want specificity for LVO particularly. The problem with this though is you have nothing with posterior circulation, no balance, no gaze, or sure, no vision, right? So it's again, LA motor scale is not perfect. So we are missing some stuff with this. Then a stroke scale as well. So we already talked about that. The rapid arterial occlusion, so the RACE score. So this is like facial palsy, arm, leg, gaze, aphasia. And now that this is getting speech, has a pretty good specificity, increase the sensitivity with this. What about the leg? So this is leg strength, eyes, visual fields, gaze, speech, language. So this is getting your language and visual fields in there. So it correlates well with the NIH over 10, which correlates well with an LVO. That was in 2014 that came out. You have your Cincinnati pre-hospital stroke scale. So I think this is a common one that is seen out there, the Cincinnati stroke scale. So this is like conjugate gaze deviation, incorrect answers to at least 2 level of conscious questions, and cannot hold up arm for 10 seconds. Pretty good specificity, really good sensitivity. NIH stroke scale correlates well with greater than 15. And then you have your VAN. So this is your vision, aphasia, neglect. Really good sensitivity and specificity. And then you have your pre-hospital acute stroke severity, level of consciousness, gaze palsy deviation, arm weakness. This is a lot of different stuff I'm throwing at you. Hopefully, if your agency is using one of the stroke scales, probably one of these ones up here. But just know that there's no perfect stroke scale. And that's the big takeaway from this. But again, the stroke scale is to identify those that are going to be candidate or potential additional therapies, particularly thrombectomy for this. So you use your BFAST as a screening tool, your stroke scale to say is severity of stroke, and then built into the protocols and transport destinations should be is where do I take this patient with a certain score on my stroke scale because I'm worried about stroke resources for this.
So we just grabbed some of these just to kind of pull the audience. I did notice a typo on B is supposed to be NIHSS, not HIHSS. So I'm not going to, and you can elaborate on the acronyms if you would like, but which stroke scale does your agency currently use? Are you using the LAMS, the NIHSS, the PASS, the RACE, or the simple 3-item stroke scale? The polling software only allows a certain number of these, right? So I can't throw all of them up there. We probably could have thrown an other in there, but these are just the ones we grabbed. If you are using other, then you could type, if you're using one of the other ones, you can type it into the question box and we can kind of add that into the polls. But I'm going to leave this one a few seconds to probably close to 10 or 15 more seconds to give everyone a chance. Hopefully, if you use it, you would know which one, right? You very amazingly rambled all the names off of these, but I used the LAMS case. That's all I need to know. So give it about 5 more seconds. Everyone's in the room going, which one do we use? Does anybody know? I think Cincinnati.
I hope not.
Cincinnati one's
Cincinnati.
pretty commonly used at the EMT level. I think the national curriculum grabs LAMS and Cincinnati are kind of the ones they unpack. But got a couple in. One says Cincinnati stroke scale. One says we use the FAST or VAN. So those were just 2 that weren't in there. I'm going to go ahead and close the poll. We got 65% use LAMS, 13% use PASS, 23% use the simple 3-item stroke scale. So we got no users of the NIHSS, which you were saying is more of a hospital one anyways. No users of the RACE. But then we have the FAST or VAN and Cincinnati stroke scale kind of added into that. So it was cool. We were wondering how many different we'd get. So that's awesome.
Yeah. And again, there's no perfect stroke scale. So I think that's, continue to follow this. And I think as we get more studies that look into this, that hopefully we're going to be refining to increase our sensitivity specificities for both. And we might see one that's coming out more superior than others. But time will tell. So our hospital stroke management, in summary for this, is that we want rapid assessment, diagnostic imaging, importance of pre-hospital notification. So our hospital stroke management is, again, set up by you identifying stroke. You're getting the proper screening stroke scale. You're taking to the right area. You're getting that IV. You're going to set up for success to get immediate diagnostic imaging, and you're notifying us so we can mobilize the hospital resources. For ischemic stroke, right, we give thrombolytics up to 4.5 hours. We can do thrombectomy up to 24 hours. And it's going to be important for blood pressure management if they're getting thrombolytics and or if they're excessively hypertensive. We'll address it, but we do allow for some permissive hypertension in there. Again, we're not doing pre-hospital blood pressure management yet. For hemorrhagic stroke, a lot of this is supportive care, meaning head of bed elevated. We do aggressive blood pressure management, seizure prophylaxis, some of the time depending on the type of bleed, and we need to reverse the coagulopathy. So the history of this is going to be key of knowing, are they on blood thinners, and therefore we can reverse it right away. And then neurosurgical consultation and potential intervention, right? There are some forms of hemorrhagic stroke that will require decompression to relieve the brain off the relieve the pressure off the brain and allow the brain to swell and or evacuate blood. So that is something that will happen on the hospital side as well. But a lot of it is supportive care. All right. Now, do you want to mention this Zodiac trial? Because this was actually, this was pretty revolutionary, this Zodiac trial that came out. And what they looked at was confirmed large vessel occlusion that are eligible for thrombectomy. And they randomized to head of bed flat versus head of bed elevated at 30 degrees. And what they found was the early neurologic deterioration, defined as increase in at least 2 points on the NA stroke scale, was their primary endpoint. And the position of supine, so flat, had increased stability and or clinical improvement compared to head of bed elevated. So what you'll see on the hospital side, if you're bringing somebody in for stroke, and if you're around there by the time we know that's an LVO, we put them flat right away. And this has really changed the management for the pre-hospital side for interfacility transport. So this is going to be, if you're doing IFTs, that you're transporting somebody from a lower stroke designation scale to a higher stroke level of care. These will be a lot of times they're transporting for IR capabilities that we need to keep those patients flat. So if they are known LVO, and it's not an airway concern, right? We want them supine because of improved neurologic outcomes in these cases. I want to stress here, this is not scene management. So if we
do not do this as
a scene responder, we are not doing this. We're doing head of bed elevator for everything we talked about, for cerebral perfusion pressure purposes, airway, comfortability, etc. But for those with IFTs that are doing IFTs, if you're picking up a transplanted patient with a known LVO, improved outcomes if we keep those patients flat. Really good study. So key points. Hopefully we are all moving towards be fast.
I think AHA, their references have now moved to be fast. I think the DVDs for the layperson, I think still say fast, but the new guidelines come out the tail end of this year, I think. So I think the idea is it's moving to be fast.
Yeah. And so that's going to increase your sensitivity to be able to detect stroke as your screening tool. So that's going to be your balance in eyes. If you're able to walk your patients, I think that tells a lot. Don't let them fall. Recognize signs and symptoms, ischemic, hemorrhagic, and stroke mimics, right? But if it's a stroke, if it looks like a stroke, treat it as a stroke. And remember, it's time-dependent emergency. The things with this is going to be typically negative symptoms. So loss of function, sudden onset, can be progressive. And then there are stroke syndromes out there, but looks like a stroke, treat it as a stroke. Do your sleuthing, identify that last known well, really important. Look at their med list, particularly blood thinners, going to be very, very, very important. Physical exam and glucose. Do not forget the glucose, the most common stroke mimic, the low-hanging fruit that you can correct here. And then your stroke scales. So whatever you're using right now, continue to use the stroke scale. That's going to ultimately determine your transport destination for this. And then the utmost important of that, once you've done all of this stuff, you're doing this in a time-critical emergent fashion, right? You're moving quickly to the hospital, and then that pre-hospital notification, getting the IV above the level of AC if you have IV capabilities to do that, to get the resources mobilized on the hospital side.
They're saying there is no absolute way of knowing hemorrhagic versus ischemic in the field, correct? There's no way of determining one versus the other. It's just a stroke is a stroke. The hospital is going to determine which side.
Yeah. Now there's something that can kind of sway your suspicion for ischemic versus hemorrhagic, but there's no way unless you have that mobile CT that you're scanning people in the field on those mobile stroke units of really knowing. And so no hard and fast. Again, it's going to become your clinical suspicion of this based off of risk factors and presentation, but you can't know 100%.
Gotcha. Next one, what are some physical assessment tools you can recommend overall that BLS providers can incorporate? This is pretty good. I like this question.
Tools such as?
I think assessment tools, right? So outside of your general sample, OP, QRST, NREMT baseline vitals, what else should BLS providers? I mean, we've added glucose, right? We've added B in front of our fast exam, but is there anything else you do? You're heavily involved with the pre-hospital world with BLS providers. What else would you expect a BLS provider to be assessing in the home of these patients or en route to the hospital that are beneficial?
That's a fantastic question. And I think it's probably going to be something that you're not going to be excited with my answer that you're already doing. And I don't like the thing is like, this is me going a little soapbox here of saying, I'm just a BLS provider. Like BLS saves lives. And that is so true of across the board, even emergency medicine, BLS saves lives. And the information you get on scene, whether you're BLS, ALS, is so important because you have eyes there that the hospital doesn't see. And this goes across all different disease processes. I'm not just talking about stroke, but this is where it's really important is that we talked about a lot of this is not the sexy stuff of EMS where we're putting tourniquets on, binding pelvises, fixing broken legs, right? Taking airways and that stuff. This is where it's really like that history and physical exam really become important. So your OPQRS, your sample history stuff, I think as you become a more refined provider, you steer away from like more acronym stuff and you have a pattern of how you talk to people and you get the information you're looking for. But I think if you get a solid history, right, and you're able to talk to family, friends, caregivers, etc., get that last known well, know that you need to check the glucose, using your screening tool appropriately. I really don't have anything to say is like extra that I would go on, but it's refining the basics. And those basics are so vital that I don't want you to overlook that or try to be adding on something. Is like really focus on what you're really good at and continue to improve on that aspect of it. And that's what's going to make a difference. I think one of the things that we talked about, but didn't really stress with this is like we said, is like, it's a time dependent emergency. This isn't where I would say is like, yeah, we need to get the history from people on scene, get the information we need, but we're not spending a lot of time on scene, right? It's like, we need to get that last on the wall. We need to get the history, their risk factors, their medication list, et cetera. But everything else, IV, glucose, et cetera, can be done heading towards the hospital, right? We don't want to, like, this is a get the stuff we need and let's get moving, right? It's not a stay in place situation.
I like it.
That's it. I hate to cut you off, but this was just a sample of one of our live sessions from one of our amazing educators. If you'd like to join our monthly sessions for free, you can follow us on Facebook by searching emsconnect.org and register for our next session. We give away an Amazon $50 gift card, and you're able to interact with our speakers in real time. If you'd like to get CE credit for attending these live lectures, then you need to become a member over at www.emsconnect.org. Our membership is only $7.50 per month, and you get access to our live sessions as well as our archive that houses over 140 hours of content by our amazing speakers. Also, you can purchase our NREMT 100% online EMT, advanced EMT, and paramedic refresher courses, again, at www.emsconnect.org. Sign up today and get educated. Hey, thanks for checking out another episode of EMS Connect on Shift. Please subscribe, review, and rate our podcast on your favorite platforms. Those ratings really help our podcast grow and reach new listeners. Also, make sure to like and follow our social media sites by searching EMS Connect on Facebook, Instagram, and YouTube. Thanks for getting educated with EMS Connect.